So yeah, I think we're going to continue to country hop. So from UK to Canada, and we have Andrew Arifin from the Department of Radiation Oncology in the London Regional Cancer Program, Canada. He'll be talking to us about remote contouring and virtual review during the COVID-19 pandemic.
Great, thanks so much for the introduction, Dr. Koch. Let me see, hopefully I can control this. All right, so I have no conflicts of interest to disclose. So the COVID-19 pandemic has led to disruptions in medical education, as shown in Dr. Meredith Giuliani's presentation. This excerpt from the systematic review here sums it up well, in which the authors state that the shutdown of academic institutions, alongside the novel challenge imposed on healthcare systems worldwide, have taken an immense toll on the quantity and quality of medical education. Prior to the pandemic, we followed apprenticeship-style rotations in which a resident was paired with one staff for 1 to 2 month rotations and followed their schedule in terms of clinical and radiation planning work. Contour review was usually done in person with staff sitting down at a computer station one-on-one, or feedback was given after the fact via email or over the phone. To limit potential exposures and encourage coverage of clinical services during the pandemic, we moved to cohorted teams with week-on, week-off schedules. During this time, there was a lack of direction or expectation regarding case contouring. Residents noticed a decrease in the volume of cases contoured and a decrease in the proportion of cases reviewed with immediate feedback, which we discussed in Michael Scherer's talk was quite important in a contour teaching. To address these issues, we proposed the Recover COVID-19 framework consisting of 2 processes: case procurement and virtual contour review. The case procurement process used a mentorship style model in which senior residents helped junior trainees with case selection. A major asset was a virtual tracking board that is used in our department that lists all cases that need contouring, their statuses, and due dates. Senior residents used this and considered staff availabilities and case complexity, whereas junior residents considered their own learning goals, availabilities, and case complexity when determining case assignment. Once a case was selected, senior residents notified staff and the assignment was tracked on a separate form to avoid overlap. With regards to the virtual contour review, we wanted to use a software platform that could replicate the in-person review process as much as possible. Capabilities we considered including screen sharing, remote control functionality to allow collaboration, audio-video calling, secure data transmission to allow exchange of patient-level information. And our institution provided access to Microsoft Teams, which had all the features we required. This is a demonstration of the contour review process. I'm sharing my screen with my colleague, Wei, who I'm engaging with using the audio video calling feature. And here I'm editing a contour using a remote desktop connection to my institution. On this screenshot, Wei has requested control of my desktop. And with this feature, he can edit the contour using my desktop connection while describing his thoughts in real time. And you can see that there are actually 2 cursors on the screen here, indicating that both he and I can edit the contours at the same time. Data were prospectively collected with residents completing a case log after each contour case was completed. Data included the type of, the data included the format of the review, the perceived educational value of the case overall, perceived educational value of the review, learning points from the case, and qualitative feedback from the program. Descriptive and comparative statistics were used to analyze the data. Panel A shows a plot of the number of resident cases contoured over time. Phase 1 was a 4-week period prior to the initiation of the program, as indicated by the red arrow, whereas phase 2 was a 4-week period after. Panel B shows a bar graph of the mean cases contoured per week, split between the 2 phases, indicating a significant difference between them. And panel C shows a pie chart showing how cases were reviewed between the two cases. We see that a large proportion of cases in phase 1 were not reviewed with the resident directly, or feedback was given post hoc or after the fact. And this changed dramatically in phase 2. And so we noticed that introduction to the program coincided with an increase in the cases contoured and proportion of cases reviewed with virtual feedback. On this slide, panel A shows overall educational value of the entire remote contouring and review process by the type of review completed, as scored by residents on a Likert scale between 1 and 5, with 5 being of best value. Panel B shows the educational value of the feedback itself, again separated by the type of review completed. We see that residents felt that the overall educational value of the entire process and the educational value of the feedback itself to be similar between virtual and in-person cases, but significantly better than those reviewed post hoc or with delayed feedback or no feedback at all. We returned to regular apprenticeship style rotations in July 2020. However, contour review is still primarily done remotely with processes established and recover. Due to the success of this program, we sought more application of this technology, such as in-house practice oral examinations, weekly oral drills, and weekly physics sessions. We've shown that virtual review can supplement or be used as an alternative to in-person review, and that this platform is a feasible way to conduct this. This allows for increased flexibility to ensure educational value is maintained when in-person activities are not available during the pandemic and beyond. A strength of our program was that this was a resident-led initiative to address an educational need. Implementation challenges included its reliance on extra responsibility for senior residents in the case procurement process, and technical support requirements such as the creation of technical support documents and having super users available for troubleshooting. Onboarding of individuals was particularly time-consuming and required buy-in from staff. Future studies could explore other applications of this technology in RO education, such as validating this approach in both formative and summative assessments or assessments involving multiple observers. And thanks so much for your time.
Thank you. Great program, great initiative, and I think something which has been very much, an issue which has been felt globally during the pandemic. A question for you about the platform that you landed on. We locally had some discussions around this, and cybersecurity was a very big concern related to it. So I'd be interested to hear your thoughts and where you landed in terms of platform choice.
Right. So Microsoft Teams, as I mentioned, was provided through our institution. So it was advantageous in two ways. The first was that it was no added cost to our program in using this platform. And secondly, it was vetted by our IT department in terms of its security and privacy features, in terms of the remote desktop connection and sharing patient level information. Although I'm sure, nothing's 100%, secure. So, but I think that it meets some of the requirements by governments and things like that.
Yeah, it's interesting. I think that seems to be a preferred solution. That's similarly what our institution landed on. But also, if anybody else has had any other platforms that are in use locally, I'd be quite interested to hear it, because I think there are some. I still feel there are some limitations with the Teams platform. Any other questions related to this particular project?
I just wanted to highlight, a great example of residents found an issue and they made an initiative to continue their education during a difficult time, and you all should be commended for that, because, your education will end in however many years, regardless of a pandemic or not. So you took that effort. And one thing that I really noted, and I think is an important concept in education, medical education specifically, is timely feedback and how important it is. You had that one graph that showed, compared to no feedback, virtual or personal was significantly greater, but compared to post hoc feedback, might as well have gotten nothing, because it was no longer timely, it wasn't tangential to the experience, and it just shows how important that is. So just a great learning point for everyone that your work has demonstrated so well.
Thank you.
Actually, one other final question that comes to mind is related to the way that you said there was a virtual board where you sort of had the list of cases that are for contouring. Is that correct? Have we still got you there? Oh, yeah.
Sorry, I muted myself.
There you go.
Yeah, we had a virtual tracking board that was already in place prior to the pandemic. And it was a way that our department kind of tracks cases, their due dates, and where they were in the planning process.
That was actually my question about whether it was pre-existing or specifically implemented for this. So yeah. All right, good. So I think we're about at time. There's a couple of other questions in the chat, but perhaps you can respond to those offline. We're back at a breakout session now, I believe.